Hello and welcome to our IVF webinar tonight. I hope you can hear me loud and clear as we are having another very important topic to discuss. I am glad to be here. I hope you had a wonderful weekend and are ready to find out a bit more on egg donation programs. And as always, I would like to thank to our ambassadors and partners for their support. And you can see them right here as well. And as you can see, more and more of those are just supporting our initiative. So thanks to them. And tonight we have a very special guest with us as well as always. And this is not our first webinar with Dr. Diana Obidniak. So I'm very happy and excited to have you back with us. So already, thanks so much for joining our initiative as well. And how are you today, Dr. Diana?
I'm great. Thank you so much. I'm really excited because we have a very interesting topic today. So I hope that it will be useful for our guests. I'm very, very grateful for attending our webinar, for joining this great initiative. And I hope that it will be fruitful for your experience. So let me introduce myself. My name is Dr. Diana Obidniak. I am the affiliated professor and St. Petersburg State University is the main university in our city. I'm also a practicing fertility specialist and the head of the International Cooperation Department of AVA-PETER Clinic. And the topic I would like to discuss with you, if you have any questions, I will be very, very ready to answer all your questions. And the topic is egg donation program. I would like to discuss with you clear benefits and the hidden risks of this program. So as we will discuss the practice issues of egg donation program, I would like to represent you the clinic which I present today, because it's necessary to understand what the expertise we can provide and why we can discuss today this topic. So the AVA-PETER clinic is the oldest private fertility clinic in Russia, and it was established in 1996. So we have offered our expertise in fertility treatment for more than 20 years. We are the largest fertility center in Russia, so we make more than 6,900 cycles per year. Every third patient is over 40 years old, so we specialize in so-called difficult patients with recurrent implantation failure, with repeated pregnancy loss, with diminished AMH level, so diminished ovarian reserve. So unfortunately, there is no way to make IVF cycles with the own eggs of the patient. So we have a very intensive experience of implementation of egg donation program. I also would like to pay your attention that we have strict external audit and internal audit, and we have our own genetic lab. So when is recommended, when we talk about egg donation program, we should just have a certain understanding when we are pushing patient to this program with the aim to minimize their time to get pregnant. For sure, we always think about patients of advanced reproductive age. But to say the truth, our understanding of this time limit or this age limit is going higher and higher, because about 10 years ago, according to all the guidelines, women over 39, 40 years old were recommended to try egg donation program. Nowadays, for us, it's always it's always a second line of therapy, because we have a very great experience of embryo banking, of different individualized types of ovarian stimulation. So in many cases, so we can manage to get good embryos with the own eggs of patients. But unfortunately, when the resources of human being, of the woman, is already exhausted, we have to implement egg donation program and make it very, very delicately. Also, egg donation programs are recommended for women with ovarian failure due to menopause or premature ovarian failure or due to ovarian surgery. For example, in patients with severe forms of endometriosis, we can expect that after surgery on the ovaries, the tissue, the volume of ovarian tissue have been diminished extremely. That's why, unfortunately, in some cases, we have to recommend egg donation program. Also, sometimes there is need. Egg donation is a solution for patients with recurrent pregnancy loss or with inability to obtain aneuploidy embryos. For sure, you will find rather similar things and rather similar descriptions concerning the donor selection. For sure, in any clinic all over the world, our aim is to make this program not only effective but very pleasant for you. That's why for us, the main thing is to get healthy baby for you. Healthy baby, and for sure we all want to have healthy babies, talented babies, attractive, beautiful babies. That's why for sure we have multiple way of selection. What we have implemented in our practice after 20 years of this experience. For us, we assess also that looking at the donors. So we consider only young and attractive women under 30 years old with own healthy baby. For sure, having their own healthy baby, it's not the guarantee for their genetic competence, and we will discuss this point a little bit later. But for us, it's a kind of approval that the quality of their eggs are already approved, and these women can produce good, competent embryos. We also possess the largest database of egg donors and vitrified oocytes in Russia. So we are proud to represent both European and Asian phenotypes. For sure, the donors undergo genetic testing on common hereditary disease, and we understand how significant and how sometimes dramatic it seems to be this decision to go into egg donation program. That's why we would like to provide as more information as we can. We provide full information about the appearance of the donor. For sure, we provide all the information about the medical background, education, hobby. Our questionnaire consists of more than 70 questions, but as we have very close relationships with the donors, for me as a doctor, the donor is also a kind of patient. So I want to take care about the donor. We have a special department of managers who are always in touch with donor to be sure that everything goes well. That's why if you need some more if you need to clarify some more details, we are wide open because our managers can always find the question, just address this question to the donor and provide you with the certain answer, with sincere answer. Because I remember then one couple, for them it was a very, very significant if the donor likes cat or dogs. And for sure, according to the medical background and according to the prognosis of fertilization rate, it doesn't make sense. But as we understand that it's a significant point for our patients, we had just to clarify this detail, and it was for our patient, it provided a great emotional comfort. As we have the largest database of the egg donors, we have no waiting list. So we have both so-called vitrified eggs in our database and our bank, and also we have a list of donors who are ready to initiate the treatment at your earliest convenience. we usually recommend to use the donor who will be stimulated just for you, because we know that fresh eggs usually are a bit better. All over the world, all the IVF clinics provide their results that we always see that the number of blastocysts at the end are always a bit more better in so-called fresh cycles. Talking about selection process, for me as for doctor is the main process in egg donation program, because we have very standardized protocol concerning embryo lab practice, and we know that it provides and guarantees great results and great survival rate for blastocysts. That's why we have to be very, very attentive from the very beginning, from the selection process of the donor. So at first we make general interview. As I have said, it consists of more than 70 questions, just to provide the basis, the motivation for the donor, why the donor want to be involved in such program. We also catch the information about the medical background, and then we approve it by making inquiries for the medical centers. We also have the database, which is rather common in Russia, so we can take this data and to control if these data were provided sincerely. Then we perform genetic testing, because for sure the main thing in egg donation program is genetic competence. We make not only karyotype, the blood test on karyotype, which is considered to be just the number of chromosomes, but we also make screening on so-called monogenic diseases. Maybe you have heard about that. All over the world, the definition of these monogenic diseases, it's like a rare diseases, and it results only when there are the both parents are carrier of these monogenic diseases. They are even considered and they are titled in many manuals as rare diseases. But unfortunately, if the clinic doesn't provide such screening, it can lead to the dramatic results. Unfortunately, even in egg donation program, without screening on monogenic diseases, there can be very dramatic histories and cases of having not healthy baby. Certainly, it's not our aim. That's why we are very, very attentive to this point. After that, when we are sure that the applicant, our candidate to the egg donation, to be involved in egg donation program, is healthy in terms of genetic competence, we initiate gynecological examination and general physician examination. So, talking about gynecological examination, we always assess hormonal basic levels. We make screening on infections, and for sure we make ultrasound scan. All these except genetic testing, because it's a constant data. Talking about gynecological examination or a general interview or a GP examination, we always make it several times, because if the donor is involved several times, we repeat all this examination before each time of initiating the program. Then the very significant point, I know that it's not a very common practice because it's very expensive for clinic, but we have implemented it several years ago, and we see the great difference, because even when we talk about young women who already have their own baby, unfortunately it's not a guarantee that the quality of egg will be good. that's why we have implemented the practice when we make so-called trial ovarian stimulation and with following trial fertilization with sperm donor. So the first time when the donor is invited to make ovarian stimulation, it will be not for patients, it's just for experience of the clinic, because we want to get information how the donor reacts to the stimulation, what quality of eggs we can expect, what number of eggs we can expect, because if I'm sure that you can relate that we are working with biological material, and when we talk about biology and physiology, we cannot control everything. We can make prognosis after having experience with this certain person. That's why it's a very good thing. And unfortunately, after some trial ovarian stimulations, we have to exclude these donors from our list of recommendations, exclude from our database at all, and even make a special remark as a sign, as a note for another colleagues, for another clinics, to make aware that these donors shouldn't be recommended. So given such an accurate and rather strict selection process, I would like to tell you that not more than 20 or 25% of applicants are approved. It's a rather strict selection process, but we really need to make it. It's our form of guarantee that we will expect a good quality of eggs. For sure, the clear benefits of egg donation programs seem to be rather clear. For sure, there is a high success rate. Success rate in different clinics in different countries differ for sure, but rather average levels, like in our clinic, it's 65 till 70%. Depending on quality of sperm and presence of concomitant diseases in couple. Because for sure, when we talk about success rate, we talk about clinical pregnancy rate. We don't talk about fertilization rate or the number of embryos we obtain, because our aim is to make you pregnant. So for sure, such a mode of selection process makes a very great influence on our outcomes. For sure, and no doubt that nowadays many clinics have good lab practice, good clinical, good practice in terms of individualization of treatment. So I really think that I'm sure that all my colleagues are dedicated to this process, and we all share responsibility. So I'm sure that all the clinics have tend to make a great control of the egg quality. But nowadays, so we talk about rather high effectiveness of such programs, but we also assess the time to pregnancy. That's sometimes the basis for recommendation, because when we talk about patients of advanced reproductive age or with minimal ovarian reserve, we always discuss alternatives, that we can make embryo banking programs, but it will take, for example, 6 or 7 months till we can start to make embryo transfer. And unfortunately, there is a risk that most embryos or all embryos will be abnormal. So after 6 months or 7 months, we may have the basis to move into egg donation program. And in contrast, if we start with egg donation program, we can minimize time to pregnancy, and because of it, making all this minimizing financial expenses. So usually, according to modern actual recommendation, because we are talking about area of medicine when usually most financial expenses are made by patient itself. So all the colleagues, all the physicians all over the world are recommended to take into the account not only effectiveness and medical issues, but also take into the account the cost and expenses the patient will take. So for sure, sometimes egg donation program seems to be the most cost-effective program in IVF in reproductive area. But what about hidden risk? Egg donation is considered to be an effective tool in creating competent embryos. But I would like to discuss with you, is it applicable for all cases? Well, I want you to show this slide. If anybody attended our last seminar, you have already seen it, but it's very significant, and I would like to share with this information once again. So, our physiology of all human beings is formed in such a way that even when we talk about young women and we obtain a good quality of embryos, we should expect that a great percent among these good by its external appearance embryos will be abnormal. If you pay attention to the slide, you can see that we have so-called 4 types of quality of embryos according to the morphological qualification of the embryos. So we assess it by their external appearance, and then trying to be closer to the patient, we want to give a conclusion what the type of quality we see talking about that embryo. So we usually divide into excellent, good, average, and poor. For sure, we have international terminal terms of communication between physicians, and in your medical report you have seen some figures and letters. For example, 4AA, 3BB is precisely the mode of assessment of the embryos by its external appearance. But unfortunately, this mode of assessment of embryos doesn't provide objective information about their genetic competence. This trial have demonstrated information that there is a really bad correlation between the quality of embryos by their external appearance and their genetic competence. For example, if we talk about excellent embryos, the prevalence of abnormal embryos among this category of the embryos will be close to 40%. It's a very high rate. Talking about poor embryos, we will find only 25% of normal embryos. So more than 75% would be abnormal. That's why some time ago we have tried to implement pre-implantation genetic testing even in egg donation program. Several years ago, it was a very common opinion among fertility specialists that egg donation program is that effective that there is no need to add more to supply it with additional technologies. But according to our empiric experience and after so-called GPP opinion of experts in this area, we have started to implement this practice, and we have presented our own results, showing that there is for sure the prevalence of abnormal embryos is lower than in general population, because the donors undergo very strict selection, and they already have approved by genetic mode of investigation. But recent, and now I would like to share with you the data of recent investigation called Major Factors Involving an Implantation Rate of PGTA Euploid Embryos in Egg Donation Program over 35 years old. I would like to share with you because these data are very, very demonstrative. So this study group of investigators performed such trial. They divided all the patients into two groups. Group A consisted of 188 egg donation program with PGT, and the second group, Group B, consisted of 58 egg donation program without PGT. So they wanted to compare the outcomes of clinical pregnancy rate and live birth rate. For sure, for us, it's not a very good sign that there is such a great difference between the number of involved program. Talking about evidence-based medicine, it's much better to compare the similar number of participants in each group, but we should take into the account their results for sure. So talking about implantation rate, they received about twice better results in Group A. So in group where the egg donation program was supplied with pre-implantation genetic testing, implantation rate was 46%. And in Group B, without pre-implantation genetic testing, the implantation rate consisted just 20%. To say the truth, it's not very high result of implantation rate, and I think that maybe in many clinics you will observe 46% of implantation rate in program without pre-implantation genetic testing. But I just want you to pay attention to the great difference between, because the technology was the same, physicians were the same, the achievement to the patient was just the same, but the result is very, very different. Also, we should realize that when we talk about egg donation program, we usually and understand that we use biological material of your partner or your husband, and the quality of sperm also plays a very crucial role. I would like to represent you the very interesting trial called Evaluation of the Impact of Quality of Sperm Morphology on the Rate of Aneuploidy in Donor Oocyte Program. So it's interesting because we have already approved data that in all programs, male factor will have impact. If we have severe male factor, for sure we should expect that the outcomes will be worse, even in egg donation program. And this is the approval that there was a significant difference between the groups with different sperm quality. So this result suggested that diminished sperm quality is correlated to the aneuploidy rate in pre-implantation embryos. If you pay attention to the test on the slide, there are very different and unfortunately very severe impact on the embryos. The author have observed total aneuploidy, monosomy, trisomy, so severe defects in the embryo. So for sure, it's not our aim. We want not just to make you pregnant, but provide you health, happiness of parenthood. So talking about good clinical pregnancy practice, for sure we understand, we suppose, pre-implantation genetic testing and selective transfer of one embryo. Why it should be so significant? Because to say the truth, I bet that we have started to make selective transfer of one embryo several years ago, and for sure physicians of so-called old school of fertility or for reproductive medicine, they were worried, they were excited because usually physicians wanted to transfer two embryos. It's associated with the technology of vitrification, of freezing the embryos. When the IVF service started, for sure we hadn't such a great technology, such a proof technology, and such safe technology of freezing the embryos. That's why physicians were not sure that this freezing would not have a bad impact on the quality of embryos. That's why they prefer to make transfer with native embryos, but not with a vitrified one. But nowadays we have just great technology of so-called ultra quick freezing of the embryos. We call it vitrification. So it's really safe for the embryos. You can be totally persuaded that it will have no risk of defreezing. For sure, we have just a tiny percent of defreezing, of non-defreezing of the embryos, but it's still very, very tiny. We don't talk about 100% of positive results, but it's close to 99 and so on. So you don't, you really don't you shouldn't be afraid of freezing the embryos. But as I have already told, my team and me personally, we see our aim and we measure our IVF success by not providing you good generation of embryos or not even with positive pregnancy test. We understand that our IVF success and our work is done just when you take your healthy baby home. Otherwise, our work is not done properly. So in that context, it's very significant and important to understand that a good embryo is not the guarantee of the pregnancy. It's just a part of a very delicate process. We call it implantation. So the very beginning of your pregnancy is the process of delicate interaction between embryo and the endometrium. Traditionally, for many, many years, understanding of this process was that there are just two main players, embryo and endometrium, and there are nothing else. But rather recently, close to 20 years ago, in medical history, it's really, really recently. So a great team of investigators, Bin Khalifa and others, demonstrated that there are still more players, commonly cells, microenvironment, and various growth factors, which play an important role contributing or hindering successful nidation. So when we talk about programming IVF success, even in patients when we know that the main thing and the main cause of ineffective IVF is bad quality of eggs or advanced reproductive age, and egg donation program can be the solution of this part of IVF, we also should assess all other factors. So we should meet the main players, embryo, endometrium, and also concomitant pathology, because we know that thyroid function of thyroid also has a great impact on the initiation of pregnancy and progression of pregnancy. There are also some features with our blood which can play a very crucial point and a very crucial role in progression of the pregnancy. So we should see the picture in whole. We should assess all these features which can be very interesting in our treatment plan. So endometrium. For us in egg donation program, endometrium is also a very significant player because endometrium plays a role of microenvironment. It is a natural biosensor of embryo quality, and it's called it has such a fragile balance between the capability to accept the embryo, we call it receptivity, and the capability of to avoid, to block the nidation of the embryo. So it's called selectivity. This balance can be altered by functional issues and morphological issues. If we talk about morphological issues, to say the truth, is one of the rather common defects which we observe. We take into the account inflammatory process, chronic endometritis, hyperplastic process. You can maybe you have heard polyps or micropolyps, or in contrast, adhesions between the layers of uterine. We call them intrauterine synecia. So just let us say that the endometrium is the internal layer of your uterus. It covers covers your uterus inside. So the cavity of your uterus can be considered as an apartment for your future baby, for your pregnancy. And embryo will assess it very properly. If the embryo doesn't like the condition, this condition do not seem very optimal or proper for the embryo, the implantation will not occur. Or we may observe so-called molar pregnancy or biochemical pregnancy, when this interaction between embryo and endometrium has started but then interrupted at the very early stage. So chronic endometritis is the condition involving the breakdown of the peaceful coexistence between microorganisms and the host immune system in the endometrium, resulting in a special type of chronic inflammation in the endometrium characterized by non-apparent clinical signs. To say the truth, it's a very demonstrative slide because the clinical signs of chronic endometritis are really very latent. So in most cases, you will pay no attention to them. For example, the characteristics of your menstrual bleeding can be a little bit altered. For example, at the age of your menstrual bleeding, you may notice some brownish bleedings, or you have a kind of clots during the menstrual bleeding because of a great flow. But most of women do not pay attention to that signs because nobody see these signs except the woman, and usually women pay much more attention to her good looking, not to the menstrual bleeding. But you should understand that your organism always tries to pay your attention to some signs of pathological process. If you brush your teeth and you notice a kind of blood, you will understand that something goes wrong, and you will make an appointment to see your dentist, or you will buy some kinds of therapy, toothpaste, but you will react. Gynecology requires the same approach. You should listen to your organism. You should be open with your physician to tell everything you are worrying about. Don't be ashamed. It's a very, very significant thing. So the prevalence of chronic endometritis differ very much. So in general population, it's not that high, it's just about 10%. But if we talk about difficult patient, so-called difficult patient with several ineffective IVF attempts or recurrent implantation failure, or especially in repeated pregnancy loss, this rate can be exceeded till 66%, which is very, very high. So usually when we see the patient with dramatic history of several ineffective IVF attempts, we always pay attention to the endometrium, especially if we talk about the history of several ineffective egg donation program, because unfortunately we see such patients all over the world. From the other side, we have functional alterations. It's a very, very interesting thing. For me as a doctor, it's a very great management of physician's approach, because it's a very thin defect, and we should remember that it can play great clinical impact. And generally, it's the basic knowledge about our physiology. It's not that implantation is just the delicate dialogue between embryo and endometrium, but this dialogue should be certainly synchronized. So we observe the synchronization of the processes of embryo development and the maximum of endometrial receptivity. When we talk about egg donation program, we already have the embryo developed till the stage of blastocyst. In 65% of women, this stage of blastocyst in natural life will be synchronized with the 6 days of producing of progesterone inside the body. That's why in many protocols, especially in our traditional understanding of preparation of the endometrium, is recommended to place the embryo into the uterus after 5 days of administration of progesterone. But actual data demonstrate that it's just about 65%. It's not that much if we talk about women happiness. That's why, unfortunately, we have patients with several ineffective egg donation programs in different clinics with good embryo quality. And from one side, it's a great happiness when we make successful program just at first attempt after just one examination. But from the other side, we see that for women, it's very, very difficult to understand that they have wasted a lot of time making an ineffective embryo transfer, wasting money, wasting their emotions and leading to emotional burnout. What I want to say that nowadays we have two tests, two examinations. They're called error test and be ready test, which are open. We can use it with the goal to identify the perfect time to make embryo transfer. It's even shouldn't be considered perfect time. It should be considered just the only right time for embryo transfer. If we know this information, because unfortunately we cannot catch this data from routine methods of examination, for example, from examination your blood samples or after making several ultrasound scans. No, unfortunately, it requires to make biopsy of your endometrium and assess the expressions of a panel of genes to be sure that we know the proper time to make personalized embryo transfer. These are the data from the investigators. So they have compared several groups of patients. All the groups were rather standardized. by the age, by the BMI, by the number of embryos per embryo transfer, but they have compared frozen embryo transfer, fresh embryo transfer, and personalized embryo transfer. You may see that comparing two groups which are non-personalized, just frozen and fresh embryo transfer, where the result is also rather high, it's close to 60%, but in group of personalized embryo transfer, the rate of pregnancy, of clinical pregnancy, was 85.7%, which is very, very high and is good. So I wanted to show you the samples of results of Be Ready Analysis report. You can see the scale of assessment. The green area, it means that the endometrium is receptive, and if we see a low number of the low number of score, it means that endometrium is pre-receptive, and if we have a high number of score, it means that endometrium is already over-matured, so is post-receptive. These data help us to know the information. Sometimes if there is a very high displacement of this window of implantation, we have to repeat these results, but in most cases one examination provides us enough information to enhance your outcomes. At the end, I would like to share with you just one case report. There is a mistake. So the woman was 44 years old. She had not 19, I'm sorry for the mistake. She had 9 embryo transfer in her medical history. 4 embryo transfer were in program with her own oocytes, and 5 in program with egg donation. She started her treatment 10 years before her application to our clinic. So these 9 embryo transfers were during 10 years of constant treatment. For sure, emotionally, it's very, very difficult. Moreover, she had rather difficult medical anamnesis. So she had endometriosis, severe endometriosis. So the first stage is the bad one form. She had chronic endometritis with severe activity and autoimmune component. So what we have done, at first we provided egg donation program with following pre-implantation genetic testing, because the quality sperm of her husband was also bad because of the age and some concomitant pathology. So we implemented pre-implantation genetic testing, and among 6 embryos, we observed that just 2 of these embryos were good. After that, when we already have gone through this limitation phase, when we were sure that we have enough embryos for embryo transfer, we started to prepare her uterus for embryo transfer. So we performed hysteroscopy. It was her uterus, unfortunately, was covered inside by micropolyps. Unfortunately, it's not that easy to detect these micropolyps by routine ultrasound. That's why, unfortunately, she wasn't told during these 10 years of experience that she has some problems with her endometrium. That's why for her it was a very, very awful surprise. But we deleted all that micropolyps. After that, we performed treatment just to be sure that given into the her presence of severe endometriosis and to recover her uterus from these micropolyps and chronic endometritis. After that, we perform delayed frozen thought embryo transfer in natural cycle because despite the age, she had rather regular menstrual cycle. And when we can implement embryo transfer with no additional hormones, we usually try to minimize our intervention and to make it a natural cycle. Also, as she had autoimmune component, we recommended PRP therapy. It's so-called plasma enriched platelet enriched plasma. We infuse it into the uterus. It's also, this plasma has a great antibacterial result activity, and also it contains many growth factors which make a very delicate recovery of natural resources of the endometrium. As a result, we obtained clinical pregnancy. We transferred just one embryo for sure, so the clinical pregnancy was with one child, and even the delivery was performed naturally without cesarean section. So talking about take-home message, I believe that implantation is a symphony orchestra. Never mind if we talk about egg donation program or conventional IVF cycle or surrogacy program or IVF cycles with testing on monogenic diseases and so on. It's always a symphony orchestra. It means that egg donation program is an effective solution only in contest for making embryo for receiving competent embryo. For sure, there are indications for pre-implantation genetic testing and its implementation in egg donation program. And in my mind, good clinical practice in reproductive field requires attentive assessment of all factors which can have impact on implantation process. Thank you so much. Take care of yourself. If you have any questions, I'm pretty ready to answer all your questions. Thank you for your attention.
Excellent. Thank you so much, Dr. Diana, for your presentation. Lots of interesting details, and that was already useful. But I'm sure you will be even more helpful to our patients right now, as it is time for all the questions. So there are like a few questions ready. So, are you ready for the questions from the patients?
Sure.
Perfect. Happy to hear that. The first question is, does the egg donation cover biracial couples?
Yes, for sure. There is no difference between biracial couples, so it's it doesn't play any significance for sure.
Okay, and there are like questions about the donors that you have. Okay, so the question is if there are any African donors or West Indian donors.
Well, unfortunately, we have no donors from Africa or India. It's just very difficult to find such donor in Russia. Unfortunately, no. It's very pity, but I cannot help you with that.
Okay, thank you for clarifying this. And so, would you offer multiple transfers? Like,
No,
is
no,
there and also is there a difference in the price for multiple egg transfer?
well, if you talk about, because I would like to clarify, what do you mean talking about multiple transfers? It's never a difference in price, but it doesn't make sense in medical issues. Our aim is to make one pregnancy, one delivery. Ideally, if it's one embryo transfer, pregnancy with one child and one and delivery, because multiple pregnancy provokes many risks associated with OB/GYN practice, not with IVF cycle. You should understand that multiple pregnancy has provides a greater risk of a preterm delivery with some problems with health of babies. That's why we have implemented selective embryo transfer. It doesn't play a bad impact on the success rate because it's quite the same, but the percent of twins is much lower. It's just minimal, and so consequently there are very few complications during the pregnancy. So we do not recommend. We can make it technically, but we don't do it because it's not. It's evident that it will do not bad, no good things, but it can provide harm for your organism.
Okay, thank you for answering this question. Next one is right here. After many failed own egg transfers, what is the average number of transfers to succeed with egg donor for healthy 30-year-old recipient with unexplained implantation failures?
Um, So I'm sorry, I do just like to clarify. So are you asking me about the average number of transfers to succeed with Oh, I mean, so it's to say the truth. There is no correlation between the number of IVF cycles with your own eggs because we expect that using egg donation as a solution because egg donation will prevent the cause of your previous implantation failures. That's why we should expect that if the donor is good, and we expect that all clinics share responsibility and improve the quality of their egg donors. And if your physician pay much attention to the other factors, to concomitant pathology, to endometrium, and if there are some defects in sperm of your husband, it's better to implement pre-implantation genetic testing. So for sure, if we pay attention to all the factors, we expect to have pregnancy from the first attempt. Always, in any situation, our aim is to shorten your time to pregnancy and make one but successful IVF cycle, especially when we talk about egg donation program.
Perfect. Thank you so much for that answer as well. And so, what is the maximum age for IVF in your clinic?
Uh, 50 years old.
Okay, perfect. Thank you. Next question is egg donation non-anonymous, or do we have a way of requesting it individually, sorry, to any donor?
Well, in Russia, egg donation is generally anonymous, but it means that the donor can provide their pictures if she is ready. So our base of donors consists of donors who are ready to share with their pictures. They are ready to make a video call with intended parents. Some of them are ready to meet you. But if we talk about the thing that of disclosure, their personality, for example, 20 years later after your baby grows up, unfortunately in Russia it's not ethically approved. So we cannot guarantee you that 20 years later the donor will be ready to meet your baby. But we have all the data of all the information concerning the donor, and we are still in touch with them. But what we can provide the pictures of the donor, we can provide and we can make an appointment for the meeting. If you want, we can make certainly a video call and provide many other opportunities.
All right, perfect. Thank you. And there's actually a follow-up. So, do we have access to their appearance as an adult, even if only showing to us and not handling it over via email? You said picture is
Yeah,
possible.
yeah, you can. Yeah, for sure, you can see the manager will ask you about what features are significant for you, what do you expect from the donor, and then send you the profiles of the donor, which can respond your preferences. The database is very large and is rather dynamic. By this moment, we have limited access to the electronic database, so the managers can send their portfolios for you by via email for sure.
All right, perfect. Thank you so much. And actually, there's a next question about the egg age, because you said only 50, up to 50. What would you advise to someone? Do you do egg donation for over 50?
Well, if we talk about transferring to the uterus of the patient, unfortunately, is restricted, but we should take into the account that it's restricted not in terms of law system, but also according to all the medical recommendations. According to World Health Organization, the reproductive age of women is under 50 years old. After that, we can discuss the implementation of egg donation program only if we talk about surrogacy program also, because it's just not safe to bring the pregnancy after 50 years old. It's very risky and it's a great stress for the organism. That's why we should be sure that your health and your organism is ready for this pregnancy. Unfortunately, over 50 years old, it's very, very risky. So you can consider IVF cycle with egg donation only in context of surrogacy program.
All right. Thank you again for answering this question. And it's the next question is regarding your presentation. You have showed the success rate. So is it based on the take home baby?
The success rate 65-70% is the clinical pregnancy rate, but as we make only selective embryo transfer and we implement in most cases pre-implantation genetic testing, the miscarriage rate is very, very low, so it's not more than 8%. It's considered to be very low, so we have great statistics in live birth rate, so it's more than 55% also.
Okay, thank you. Next question is, are there any cases that egg donation doesn't work at all after trying many times before of unexplained implantation failures and they have to turn to surrogacy? How often does this happen?
Well, for us, surrogacy, it's always the maybe even the third line of our recommendations, only when we have understanding that there is no opportunity for woman to bring the pregnancy herself. So only because I would like to share my opinion, and which is rather common for many experts, that unexplained implantation failure is in most cases just the lack of tests provided. In many cases, it's just associated with not performing tests of implantation window, not great quality of hysteroscopy provided. So unexplained implantation failure, usually it's just the diagnosis, which is diagnosis of our desperation, that we have by this moment no evidence-based tools to verify the reason of your problem. So for sure, for us, it's also the pain. In many cases, if we talk about surrogacy program, usually we have or the certain diagnosis, which can be associated with the competence of uterus, or there can be contraindications for childbearing from other systems. For example, there is a heart disease or lung disease or autoimmune problems or kidney problems, because our center is affiliated to the center with treating the disease of kidneys and treating the disease of intestines. So we work with rather difficult patients. That's why we have an intensive experience of surrogacy program, but it's not such a common thing when we move to surrogacy, because we have unexplained implantation failure. We move to the surrogacy only when we understand that there is a great problem with the uterus which cannot be fixed by this time, by this stage of development of medicine. So to say the truth, it's a very, very rare situation when we talk about unexplained implantation failure. To say the truth, I can't even remember when we moved to surrogacy because of unexplained implantation failure. We always try to find the reason and fix it. So usually we find the reason.
All right, perfect. Thank you so much again for answering this question. Next one is right here. So, do you have any take home baby guarantees?
Yes, we have such a program. If there is what we guarantee that if in case if after 3 embryo transfer the pregnancy is not achieved, you can take your money back. You can take the refund of 50%, or you can continue your treatment till the pregnancy comes without additional expenses. We have such program. They are rather popular, to say the truth, because for sure patients need this information that we share the responsibility, not only talking about, not only providing emotional support and being in touch and just doing our best, but also in terms of financial relationships between the clinic and the patients. So yes, we have such programs, and they are rather popular, to say the truth.
All right. Thank you so much once again for answering this question. Next one is right here. The borders are closed. My frozen donor sperm is in another country where I will go ahead with egg frozen donation. Should I start now, as I'm not needed to be there to create the embryos? They have sperm and they have my donor. They could freeze the embryos and wait for me while going with PGS. This way, I would have a clear situation when the borders are opened and I could travel for a transfer, saving the waiting time. Is this risky to freeze and unfreeze in this way?
Well, for sure, thank you for your question. For sure, it depends on the country you're meaning, but nowadays, European Society of Reproduction, American and Russian Society for Reproductive Medicine have established a protocol of safe practice, especially if we talk about both vitrified egg donor and sperm donor. So if the clinic follow this strict standardized protocol, it considered to be very healthy. So, but for sure, it's better to ask this question for your physician who knows the internal information in this clinic and can talk with you sincerely about the situation in country. So if we talk about, for example, in Russia, we perform such cycles when we do not mean that the patient will come to the clinic. So we can make, if we start cycles, we only mean that we will make a freeze all cycle. So we will not make any embryo transfers, and we are freezing the embryos. According to the available data, there is a minimal risk of infection of making the embryos or genital cells infected. So for sure it's considered to be rather safe, but it's better to discuss with your local physician.
Of course, thank you so much once again for your question as well as your answer to that. So we were talking about age limit at the clinic for the patients, but what is the age limit for the donors?
We do not consider the donors over 32 years old. So usually the average age is 25, 28 years old, but not more than 32.
Okay, thank you. Next question is, I put on weight average 4 kilos with every transfer. Would you recommend to lose before trying again? I'm 171 centimeters, 78 kilograms. If I get pregnant now, could it be too risky to gain pregnancy weight and be around 100 while pregnant?
Well, for sure, the main thing in your question is that you have put on weight average 4 kilos just after every transfer. So unfortunately, maybe the intervention, the medical prescription was a little bit tougher than it should be in your case. So you should. I bet that it's better for you to make a consultation or provide your hormonal test and discuss it with endocrinologist or with the fertility specialist if your specialist has such competence. But for sure, in any situation, if we have a problem, we should find the reason at first why you have this problem. Just after that, we can make individualized treatment plan. In your situation, for sure, it's also abnormal thing, abnormal reaction to this fertility treatment. Maybe it's associated with emotional insufficient, with emotional unsatisfaction because of bad result. Maybe it was. It's the result of some abnormalities after hormonal prescription hormonal medication. So for sure, if making the response for a question, for sure it's better to lose some weight. It's not a criminal situation in your point for sure, but it's not it's not comfortable for you. That's why it's better to verify the reason why you had start putting on the weight and try to fix this problem before embryo transfer for sure.
Okay, thank you so much again for that advice. And how do you calculate the implantation window in an artificial cycle as it is not necessarily linked to the endometrium thickness only?
Well, the implantation window is measured using this, is identified. It's not measured, it's identified with these two methods we have mentioned then previously, so-called error test and be ready test. So both methods require remodeling of artificial cycle or natural cycle. We just make the same preparation of the endometrium as we are planning to do during the embryo transfer cycle. And just at the day when we would make the embryo transfer, we are taking the biopsy from the endometrium, and then according to the genetic testing, we analyze the expression of the genes and then have the conclusion what time, if there is a replacement of implantation window. So there is no correlation with endometrium thickness between implantation window and the thickness, but for sure thickness of endometrium also plays an important role. There are data and it's already well known that we need at least 7 millimeters for successful embryo transfer.
All right, perfect. Thank you so much for answering this question and providing the details. As there was another question, could you explain the ERA test? But in such case, all is clear, I hope, right now.
Yeah.
Okay, let's go to
If
the
you need to
next.
clarify more, I just repeat your questions.
Yes,
Okay.
of course. Just go ahead and type it in if you need anything else on that, of course, as well. And so, does blood time matter with egg donation?
No. No. Well, if we talk about enhancing the result, for sure, no. But we always try to, and we just implement and practice that we try to find the egg donor with the same blood type as the woman has or her partner has. It is not associated with good or bad outcomes. It's just in case the couple doesn't want to disclose their status to everybody, just to prevent the risk of disclosure of this information. For some reasons, the baby can have indications, for example, for blood tests, and if there will be different blood types with the parents, for sure it would be rather obvious that egg donation program was implemented. So we just want to prevent such social risks.
All right, excellent. Thank you once again for that. And there are like few questions left, so we will be slowly finishing. So if you have any questions left, just go ahead and type it in. This will be like our final call for those questions. And now let's have a look at the next one here. How likely is chronic endometritis in a case where there have been 3 failed embryo transfers? After how many does it start to become a major concern? Also, can this be tested for before treatment begins?
Well, thank you for your question. As we have mentioned during the presentation, recurrent implantation failure, and if unfortunately you have 3 failed embryo transfers, for sure it's considered to be recurrent implantation failure. So, the chances of to find the chronic endometritis also depends on the quality of embryos. If the quality of embryos was good, according to the available data, the prevalence of chronic endometritis will be close to 60%. If the embryo was not so good, the prevalence will be lower but still very high, close to 45%. So for sure, after 3 failed embryo transfers, according to all the guidelines and according to the experience, I should recommend you to pay your attention and to make proactive diagnosis of the status of your endometrium. So the golden standard of evaluation of the endometrium is hysteroscopy. And the thing is that hysteroscopy is the method of visualization when we insert a thin camera into your uterus. So it's minimal invasive, but by inserting the camera inside the uterus, we can assess the status of the endometrium, the golden standard, but we also can perform the first stage of the treatment. So if we see some polyps, because sometimes the location is of polyps doesn't afford to see them, to notice them by ultrasound. That's why hysteroscopy gives much more objective information. But during hysteroscopy, we can not only detect the pathology, but we can also start to fix this problem and initiate the surgical stage of the treatment. So for sure, you have to pay attention to your endometrium, and the golden standard will be to start with hysteroscopy.
All right, perfect. Thank you once again for that question and your answer. And now let's go to the next one. I have endometriosis, and my doctor said I might have an issue with immunity system. Do you recommend any treatment before a transfer when a woman has endometriosis, any injection or cortisone, etc.?
Well, for sure, we're talking about endometriosis. there is an approved protocol when the treatment of endometriosis should be combined. So I would like to have more information how the endometriosis was verified in your case. It was if there were any surgery for to make a certain diagnosis, for example, laparoscopy or hysteroscopy, and or it was a suggestion by ultrasound. But for sure, endometriosis requires to make it's not no surgery, just equality. So it's not the basis to have the diagnosis of endometriosis. At least there should be serial ultrasound if we talk about endometriosis of uterus. If we talk about endometriosis, so-called uh, external genital disease, so endometriosis in ovaries or in your abdomen, we cannot see it by ultrasound or by equality. We can make a suggestion, but we have to prove it. At least please make blood test called CA125. It's a blood test. It's better to make it twice during one menstrual cycle, one time during your menstrual bleeding, and the second time during the middle phase when we can expect your ovulation. Because if you have endometriosis, no doubt you need to have treatment. By this moment, we have approved tools. They are rather easy for intake. So first line treatment is now the tablet, which you have to take once a day at the same time constantly for at least 3 months. But endometriosis requires to be staged because there are 4 stages, and the tactics, the treatment plan will differ depending on the stage of the disease. So for sure, if you have endometriosis, it's better to be better examined, if I think. So if we talk about treatment, we don't talk about cortisol or injection. For sure, endometriosis has autoimmune nature, but the pathogenic treatment is not associated with injections of cortisol. Is the treatment of endometriosis. But by this moment, you haven't had the diagnosis yet. You have the suspicious things telling that you may have endometriosis, but it's better to approve it and make treatment prescriptions only after a verification of this diagnosis.
All right, perfect. Thank you once again for that answer to this. Okay, next question is: do you recommend frozen egg donors over fresh during this pandemic?
Well, for sure, I recommend to make everything safe. If we by this moment we have standardized protocol how to act during the pandemic. It's the same protocol for all the countries. The indications and the tools of prevention of the risks is the same in all countries. So I bet that even using fresh donors are the safe the safe tool when is already allowed, because if it's not safe, your clinic, your physician will never recommend it or will never make this possible to do. We have already protocol to perform fresh cycles, and I know that in some countries they have already started to make ovarian stimulation of the donors, and it's just the same cycle. By this moment in Russia, we do not do any ovarian stimulation. not for donors, not for patients, but we expect that um, we will start it not later than in a month, because in 2 weeks we expect that it will be totally safe, so we will wait a bit more. I expect that in other countries it can be already safe, because the process was a little bit earlier, so in that countries the process is already at the stage of recovery. So I'm sure that you should ask this question to your physician at your clinic. I bet that he will answer very sincerely, because each physician wants just to make you nothing but good. So I'm sure that your doctor will answer you very sincerely.
All right, perfect. Thank you so much once again for that. Okay, next question is up. Does your clinic generally perform other tests as standard, like pelvic exams, fiber detection, etc., to see if there are factors that may affect reception of an egg?
Yes, for sure. It's just the normal, it's just the standardized form for everybody. So we have recommendations from the medical committee of Russia, Medical Society for Reproductive Medicine. So we need to make all the examination you have mentioned just in each situation, because the pregnancy is a very long journey. So we should be sure that it's safe to make embryo transfer, that your uterus is capable to bring the baby. There are no no defects in different organs that can get worse during the pregnancy, because pregnancy is a stress for the whole organism. It's physiological process, but it's still a great stress for the organism. That's why you should be in good form. For sure, not there is no person who is in perfect form for pregnancy, but some of such problems can be treated before. Some of the problems can be treated even during the IVF cycles, but some of them can be risky and can be considered as a contraindication for IVF or contraindication for carrying the pregnancy. So for sure, we should assess it before making treatment plan for the patient.
All right, perfect. Thank you again for answering that question. And a few left. Next one is right here. What my chances of getting pregnant with my own egg at 44-year-old with an AMH of 0.2 FSH 35?
Well, unfortunately, I should tell you that the chance of making successful program with your own eggs is not high, for sure, and is not associated with your AMH, but is mostly associated with your age, because we know that there is a strong correlation between the prevalence of abnormal embryos in population and the age of women. After 35 years old, the general risk of abnormal embryos increases. After 39 years old, we see extreme elevation of such risk, and we see that about 80% of the embryos will be abnormal among those which reach the stage of blastocyst. Unfortunately, not many women after 33 years old produce eggs which can develop till the stage of blastocyst. For sure, we obtain the eggs, there is no doubt, because we have 19 modes of ovarian stimulation, so we have a lot of feasible methods of individualization of your treatment, so we will obtain the eggs. But unfortunately, the quality of those eggs will be very bad, just because of the age limits, for sure. So we had, to say the truth, I had the woman who had her own baby with her own ex at the age of 48. It's the record in our clinic, but she had now the features of her hormonal levels, of her hormonal test, and she should be considered as a exclusion. You had, according to the lab test, you have provided FSH and AMH, which is very which demonstrates very physiological changes. So you have normal physiology of women, but unfortunately, we expect that the quality of embryos will be very bad, that there is a great risk that we will have no normal embryo for embryo transfer.
Thank you for clarifying this as well, of course. And now let's have a look. There are like 3 questions left. Due to the fact that borders are closed, would it be possible that you ship the frozen eggs from your database to another country where I can enter and where egg donation is allowed?
Well, yes, for sure, we have even our own shipping company, but I think that during the following months, it will be just impossible to make this shipping, because I think that the following 1 or 2 months, all the countries will be a bit worried of some transportations or some active movements. So I think that if you are ready to wait for a month, it's okay. But I'm not sure that we just manage to make this shipping during the following months.
All right. Thank you. We are all waiting for that to be possible, but we need to be simply patient still, right?
Still,
All right.
still.
Thank you. And okay, there's another question about, do you do the ERA or Be Ready test in your own clinic or send it to another lab or country?
We perform it, ERA test we perform in Russia, and Be Ready test we send to Estonia. It's very close to St. Petersburg, so it's not a problem. But Be Ready test is cheaper, so is more affordable. That's why even we including the expenses for shipping to Estonia. So the effectiveness and the objectiveness of the data are comparable. Is comparable. That's why we always discuss with the patients 2 alternatives. Because in terms of effectiveness and providing reliable data, these both tests are good. So sometimes if it can be made cheaper, for sure we want to minimize financial expenses. That's the only thing.
All right, excellent. Thank you for explanation this to this one as well. And next one question is, with DNA test an egg donor with a child, will the child DNA be the same as the couple, as that of the couple? Sorry.
Well, the child will have DNA from the husband if we use egg donors. So the child will bring DNA from your partner or your husband. But the actual, so there will be no genetic connection between woman and between the child. But actual data provides certain information, and it is very I have cheered all my team up that as a woman carrying during the pregnancy has like a trophic function for the baby, so her blood circulates also inside the embryo. it provokes and it regulates all the expression of all the genes. That's why even by appearance, even by the character, child will be very similar to the girl, though to the woman. Though genetically, for sure, there will be no connection.
All right, perfect. Thank you once again for that clarification. Next question is up right here. I had hysteroscopy recently with the doctor removed it. Was that a sign of endometritis? And how long until they will possibly come back if there is this possibility?
I think that remove them, it means remove polyps. So the polyps, if the certain we can verify endometritis using so-called immunohistochemistry by detecting CD138 or CD56. So it requires special staining of the samples or the biopsy of the endometrium. But if the doctor have removed the polyps, for sure it's the very pathognomic sign that you had chronic endometritis. But removing the polyps is just the first stage of treatment. You have to prolong the treatment using medications. What kind of medications usually if is identified depending on the pattern which was observed during the hysteroscopy, because and according to the conclusion from pathology, we should assess not only the morphological process but also assess the activity of inflammation. So if the inflammation is rather active, there is need for antibacterial therapy. Sometimes there are also in some mode micropolyps in the area of the uterus. There are connections, adhesions. They can be very slight, but we still need to implement some ferment activity or PRP therapy. So for sure you have to complete the therapy as a prevention of regression of recidivia of chronic endometritis and the polyps. But unfortunately, I cannot give you just the standard protocol because we are standing that the treatment should be individualized and should be evidence-based. So just the presence of polyps doesn't provide enough information concerning the activity of the process and the stage of the process. That's why I just can persuade you that you have to complete the therapy to prevent the recidivia. But unfortunately, I cannot provide you the certain administration list.
Of course, thank you so much. And there's a follow-up question, okay, from the very same patient. I am afraid my lining will not grow for egg transfer as I am no longer having regular periods and it is normal maximum 6.5 millimeters. Is there anything rather than estrogen that can be prescribed to thicken the endometrium lining or that would work better than this?
Well, I think that it should be performed in parallel model. If you have dysregular period, disrupted period, for sure, you should check your hormones and your physician should normalize your period. For sure, it's just the first line. From the other hand, if you had already problems with, according to hysteroscopy, you have your physician have deleted the polyps. Sometimes after the deleting the polyps, if it was tough intervention, it wasn't so delicate, or your resources do not allow to make a great recovery naturally, sometimes we recommend PRP therapy as a tool of regenerative medicine to help your lining to recover certainly and to start growing. But first of all, for sure, you should find the reason. It should be, if the lining doesn't grow, we call it resistant thin endometrium. We should find the reason. Maybe there are two reasons: abnormal menstrual cycle, dysregulated menstrual cycle, and the presence of inflammation. And you should work on both directions. So for sure 6 and 5 millimeters is very close to our aim. For sure it's better to have more than 7 millimeters, but it's much better, believe me, trust me. I had patients with endometrium not more than 4 millimeters, and we have treated till the normal meaning. So uh, don't be desperate. It's really a not bad thing. You have to just take everything into the account. Listen to your physician. I'm sure that your physician will find the key to your endometrium and prepare it properly.
Perfect. Thank you so much once again. And now the question is, does embryo glue help implantation?
Well, embryo glue was suggested several years ago, but and we tried it, as we always try everything new, trying to enhance the results. But unfortunately, this supplement disappointed most clinics and most physicians I have with whom I have discussed this invention. If we nowadays we consider as the kind of, so embryo glue, it means that we add something which will help the embryo to implant. By this time, we can consider granulocyte colony stimulating growth factor in mode of injections, subcutaneously in the abdomen or in the arm, and it for sure will help because it's the systematic activity which fix the problem of deficits of GCSF in our organism, and precisely this growth factor plays a role of this natural glue for implantation. So that is the reason we do not implement embryo glue anymore, because it doesn't work to say the truth. But we have implemented a kind of glue, embryo glue, but we administer it not during the practice of embryo cultivation, but just from the day of embryo transfer.
All right, perfect. Thank you once again for answering this question. It looks like it will be our last question for today. So let's have a look. Can you do a hysteroscopy and be ready test at the same time?
Yes, for sure, but you should, but we should follow the instructions of preparation to be ready test. So we will make hysteroscopy from day 19 to 22 from during your menstrual cycle, and 5 days before hysteroscopy, you should start to take progesterone. Usually we administer in the form of vaginal gel because it's so-called micronized, so it's very similar to the natural ones, and it's considered more closer to our organism. But for sure we can make it just at the same time.
All right, perfect. Thank you so much for all of your questions, and Dr. Diana, for your time and for answering and all the questions and for your advice. There are many comments coming up right here, and therefore I would like you to see them. So as you can see, lots of them. And actually, there is a question: Can you be my physician? So
For sure, it's an honor for me. Thank you so much. Thank you for your attitude. I wish you everybody to meet your pregnancy, to meet your baby as soon as possible. But please be patient, because I understand. I'm sure that you will manage your main dream. You will realize your dream and you make your dream come true very, very soon. But please be patient. I know that in many countries the situation gets more and more stable, but please wait a little bit more just to be sure that you're perfect. Your victory in IVF cycle will be just under the safe conditions. Thank you
Excellent.
so
Thank you so much, Dr. Diana. It's always a pleasure, as you know. So I'm definitely hoping we are going to do it again, and I'm sure we will. All right. So, so everyone, thank you so much for joining us, Dr. Diana. You have been excellent. I just want to remind everyone that. This event has been, of course, recorded. Therefore, within the next few days, it will be uploaded on our site, myivfanswers.com. So just go ahead and also subscribe to our YouTube channel. That way you will be notified when the video is uploaded. It's very useful, very easy, so go ahead and do it. Plus, I just wanted to let you know that we are having another event at 8 p.m. UK time tonight, so I hope to see you there, as well as we will go to Portugal this time. So another topic to discuss. And well, take care, Dr. Diana. Take care, all of you.
much.
Thank you so much, and have a lovely evening as well.
Thank you.
Bye.
Bye.